precise and the cost-effective method to treat patients with radiotherapy is to use gold anchor with tracking. My name is Ingemar Näslund. I have 50 years experience in radiotherapy as a radiation oncologist. For 35 years, I was working at the Karolinska University Hospital, and for 20 years, I was head of the radiotherapy division. We had 8 accelerators, CT, MR, brachy HDRs, and we treated 3,500 patients per year. During my whole life, I have been interested in inventions. I had an interest of technique. So during my education, all the time I worked at Karolinska Hospital, I had a parallel interest in inventing products. I invented gold anchor before I retired 2010. And now I'm working with that product, and the company is growing very well. And I'm working with my 3 children, my daughter's husband. So we are 5 who runs the company today. During all my 35 years at Karolinska University Hospital, there was different kinds of steps when the computers got better and better, and the imaging technique got better and better. And that raised the standard, and we could squeeze the target volume more and more against the tumor and lower the dose to the healthy tissue. When we decreased the volume, we had to position the patient more and more accurate. So when we got the patients on the table and had cone beam CT, we can position both the patient and also the tumor in many cases. But there was something more to add to this, and that was fiducial markers. When we had fiducial markers, it was very, very simple and easy for the staff to position the patient. When they had the fiducial markers, there was digital. It was right or it was wrong. But you didn't have the fiducial marker, just cone beam CT. It was a grayscale. Is that good? Is that good enough? Sometimes the nurses had to call the doctors and wait 3, 4, 5 minutes. The doctor would come and say, okay, this is okay. And then perhaps the patient had moved during that time. So with the fiducial markers, it was more easy for the staff to work. It was right or it was wrong. It was easy to see. And later on, we could also track the tumor. We could see how the tumor moved during treatment with tracking the fiducial markers. And that is the most exact way you can do treatments today. I had a very tight relation with the physicist. We had a very big physicist department. And I took a fika, that you have a coffee break in the afternoon together with the physicist all the time during many years. And we discussed different things and tried to develop new things. And then we came up with the idea that we could treat liver tumors to eradicate them in one shot, one big dose at one moment. And that was very important to have a precise position of the patient. So we started with having the patient in a vacuum pillow and made marks on the skin and so. But Ingemar Näslund, the physicist, came with an idea to position this vacuum pillow in a frame with rulers. So we could position the patient in an XYZ coordinate system. And that was much better. And so we used the CT and we put the XYZ coordinates. And then we had the patient on the couch, the treatment couch, and positioned the patient according to the XYZ coordinates. When we made some tests on the simulator, we saw that tumors in the liver, as we knew, was moving a lot during breathing. So I came up with the idea that we should put a pressure on the abdomen to put the diaphragm upwards as much as possible, and that reduced the movements of the tumors in the liver and also in tumors in the lungs very much. So it was much better covering of the tumor with less volume. So then Elekta came with a frame that they built as a product, and that had this ability to position the patient according to XYZ coordinates, and also something over this frame that could compress the abdomen. And that was the beginning of SBRT. Our first patient was treated in 1991, and the first paper came in 1994 describing the technique, and the second paper came in 1995 describing the outcome of a number of patients. When Elekta made the frame, they started to launch it and sell it to different hospitals, and then we had an education at the Radiotherapy Karolinska University Hospital, and doctors from all over the world came for this education for SBRT, and also Bob Timmerman from USA, and he became the spokesman in USA for this new technique. SBRT is high fraction doses, few fractions, and high precision. When you position a patient in a stereotactic frame, you position the body correct, but internally you have the tumor moving. And it's very good to have Fiducial markers and as internal reference points. Then you can position the patients even better and also track the tumor during irradiation. About the year 2000, we had the urologist to place Fiducial markers in prostate. It was done with thick needles and a thick marker. We had to have thick markers because it was only MD on the accelerators. So after a while, I realized that KV imaging devices could come on the accelerators. And I wanted to have Fiducial markers in other organs also, but that was too risky with these very thick needles, with bleeding and infection and so forth. So I was wondering if I could have a thin needle, 25 gauge needles. It is 0.5 millimeter. I knew it was used for fine needle aspiration cytology without any problems. So I started to have a gold wire which was fit into this needle, and I made some cutouts in it. So when I press the gold wire out of the needle into the tumor, I could see it collapsed and made a big mass of gold. That was good enough to see it on KV imaging. So it worked very well. I implanted in the liver, in lungs, in pancreas, in some metastases, and it worked very well. So we got the CE mark in 2009 and FDA approval in 2010. The unique properties of gold anchor is the fine needle. The fine needle can be used wherever you want, almost wherever you want, to implant markers without having bleeding or infections. We know that from fine needle aspiration cytology, which is very, very safe. The second advantage is that when you insert the needle into the tumor and press out the marker, it starts to collapse and expands and will be stable in the tissue immediately. So when you withdraw the needle, this marker can't go in the needle tract. That is very good because then you can immediately proceed with your further planning of the treatment without sending the patient home for 1 or 2 weeks to come back. The third advantage is that it contains a small portion of pure iron in pure gold, and that makes it visible on MRI. A precise and cost-effective method to treat patients with radiotherapy is to use gold anchor with tracking. Looking into the future, I now developing a product for sampling fine needle aspiration cytology. When you take a sample from a breast tumor, directly afterwards you implant a gold anchor. And then you treat the tumor with high-dose SBRT without surgery. That's what I think will come. Then I invented 3 things: sampling, marking, and treatment.